So we know that for young, fit patients with CLL, if they have the lower risk mutated IGHV, that they can enjoy very long-term survival after an initial 6-month course of FCR, perhaps even functionally cured of their CLL. We also know that patients who have more aggressive unmutated IGHV typically do not have long remission durations, and those patients may benefit more from continuous treatment with BTK inhibitor drugs like Ibrutinib. So we hypothesized with the iFCR study that if we combined Ibrutinib with FCR, so-called iFCR, that we could extend the potential benefit for functional cure from the mutated patients to also include these unmutated IGHV patients. We had previously published the study with short follow-up and showed high rates of undetectable MRD in these patients, irregardless of their IGHV status. And at this ASH meeting, we presented updated follow-up now with 40 months of follow-up on the patients, and we see continued very deep responses. And in fact, the rates of complete remission increased from 33% to 55%, and the rates of undetectable MRD remained at around 84%. We've only had 2 progression events so far with this median of 40 months, and in general, this regimen has been fairly well tolerated. We did see a couple of cases of myelodysplastic syndrome, which is a known risk with FCR, but these patients have been doing well after transplantation. So this study certainly suggests that there may be benefit for long-term remission for the IGHV unmutated patients, but we need much longer follow-up to understand that. It's not a regimen that I would yet to be considered a standard of care for CLL because this is a single-arm investigator-initiated study. So we're hopeful that this will lead to the development of a larger randomized experience, which could hopefully help to change the standard of care for these young fit patients with CLL.